It gives me great pleasure to introduce Professor Ahmed Osman, who will speak about living donor, lobar lung transplantation, radiological facilities for preoperative assessment.
Assalamu alaikum. First of all, I would express my appreciation and for the organizing committee for their invitation. This is almost the second or third time consecutively in the conference of chest TB and chest disease and TB. ليها شرف طبعا. أتمنى إنها تكون يعني دايما متواجد معاكم يعني كل سنة إن شاء الله. كل الشكر طبعا للدكتور محمد عوض والقائمين على المؤتمر وبالنجاح دايما وكل سنة. شكر واجب للدكتور محمود على السبورت الاندلس في البروجكت بتاع اللونج ترانسبلانتيشن. هنتكلم على النير فيوتشر دريم ان ايجيبت. خلاص ان شاء الله يعني ربنا يسهل لنا الاحوال. It's my honor to be one of the team regarding the radiology in lung transplantation team in Ain Shams University. Of course, this is our target, to improve the lifestyle and of these miserable patients who, of course, lung transplantation may be the only solution for these patients, dramatically improve the health status and decrease the morbidity and mortality, and at least improve the lifestyle of these patients. For the time sake, we will discuss only the preoperative rule of radiology in preoperative assessment of patients with lung transplantation. Regarding the recipients, our protocol is the chest X-ray once daily, 1 week before the surgery as a baseline study, and to exclude any infection during the hospital stay preoperatively, CT for lung volumetry and complete lung analysis. Perfusion scan may be indicated in some selected cases. Mammography, DEXA scan, and coronary ultrasound, carotid, and lower limb venous and arterial Doppler will be discussed. Of course, CT volumetry and CT complete lung analysis is a cornerstone of radiology in preoperative assessment for post-recipient and donor. Regarding the donor, preoperative include chest X-ray as a baseline study and pelvic abdominal ultrasound. Also, CT volumetry and complete lung analysis for both donor is also considered the cornerstone of our rule regarding lung transplantation. X-ray, as we said, is the preoperative baseline study for both recipient and donor. Regarding the CT, which is the main corner, we usually make a tailored or fashioned technique for the recipient donor, starting by non-contrast CT assessment to detect any calcifications in mediastinum, then followed by CT arterial phase, including the pulmonary arterial system and venous phase to imaging of the pulmonary venous system. Sometimes we just do the non-contrast and jump directly to the venous phase, taking in consideration adequate timing to make post-pulmonary circulation, pulmonary arterial and venous system are enhancing with contrast. Why we do a CT for both recipient and donor? First of all, for parenchymal analysis, for regarding the donor to exclude any missed or asymptomatic lesions. For example, the nodules, which can be assessed regarding the Fleischner Society, British Thoracic Society, and how can we deal if we find a nodule, if it is important enough to exclude the patient as a donor or not. Detection of even bronchogenic carcinoma, non-asymptomatic, detection of any asymptomatic lung disease as airway trapping disease, bronchiolitis, small airway disease. 3D volumetry for post-recipient donor is one of the most important preoperative assessment for anatomical matching between the recipient donor. We take a lower loop from the donor to justify only ipsilateral lung, right donor to the right lung, and left lower loop from another donor to the left lung. As we see, this is right lung. We just put a lower loop, we can assess the volume, the anatomical volume of the lower loop of the donor and how it can match the right hemisthorax of the recipient. Most of the paper are talking about 200% upper threshold for the difference between the recipient and donor. And regarding the lower threshold, there is a little bit debate ranging from 30 to 40%. Why it's very important to do volumetry between the lower loop of the donor and the lung of the recipient, because too large donor lung may lead to pulmonary atelectasis, scarring, and decreased lung volume, while small donor lung lead to intractable pleural effusion pneumothorax. And of course, it must be highlighted for the surgeon before starting the transplantation, because each of these problems may make a modification in the surgical technique. After parenchymal assessment and 3D volumetry assessment, we make a complete tracheobronchial tree analysis for the whole tracheobronchial tree branching and classifications of the all segmental bronchi, origin and their course, to exclude any abnormal course of the segmental bronchi, which of course affect the decision for surgery. Also, one of the important points during tracheobronchial tree assessment is the measurement of the diameter of the main right and left main bronchi of the recipient and the left and right lower loop bronchi diameter, to see how they can match for decision of the way of anastomosis, whether it's comparable to do end-to-end anastomosis or there is a big difference to do another technique during anastomosis, which is the telescopic technique. This is a post-operative CT for a patient with lung transplantation. Here, there is an end-to-end anastomosis. Here, there is a telescopic technique, but unfortunately, this patient has a complication in the form of endoluminal flap. After completing the tracheobronchial tree assessment, we jump to the complete vascular assessment, either the arterial or venous assessment, also to make a complete mapping for the pulmonary tree and the pulmonary venous drainage to detect any variant during the drainage or even the origins of vessels, which also affect the decision of taking a donor or modification in the surgical technique. This is a demo for a 3D analysis already settled in our Ain Shams University Specialized Hospital and in the Demirdash Hospital. This is a demo for the patient who would make a CT pulmonary angio for pulmonary embolism, not for lung transplantation, but we can use it as a demo. We can pick the complete tree of the pulmonary arterial tree in all angles, and we can confirm the segmental branches of each loop separately and confirm the origin and the relation with the other segmental branches regarding the pulmonary tree. And this will affect, of course, the selection of the donor patients on every loops and every segmental branch of the pulmonary tree. The same for the pulmonary venous system. We can assess every segmental and pulmonary vein, how can drain in the left atrium, and the relation between the venous system, arterial system, and the tracheobronchial tree. All the anatomical details regarding the recipient and donor can be obtained by this new technique and 3D analysis. The whole picture of the whole lung and the relation of the arterial, venous, tracheobronchial, and the relation with the loops. These are an examples of the variants which may affect the selection of the donor, and we can exclude donors for any anomaly. For example, V6 return separately in the left atrium, which will affect the selection of the lower loop. Regarding the recipient, besides the complete vascular analysis and tracheobronchial tree analysis, we can also assess the severity of the disease in the recipient and to what extent he is need for lung transplantation. Lastly, during CT, we can assess the complete thoracic cage, bony thoracic cage, to at least exclude one of the contraindication for lung transplantation in the form of dorsal kyphoscoliosis. Also, the lower neck cuts in CT can alarming presence of some disease, for example, huge multinodular goiter, which must be alarmed for the anesthesia team because it's suspected to be a difficult intubation patient. Regarding the ultrasound and Doppler, pelvic abdominal ultrasound is done for the recipient and donor to exclude any hidden or underlying non-manifested liver or renal pathology. Carotid lower limb venous and arterial Doppler is indicated to exclude any minor arterial insufficiency or chronic DVT, and also is very important before ECMO introduction, which is needed for patients intraoperatively for patients with lung transplantation to assess the caliber of the main vessels, the common femoral artery and vein bilaterally, to exclude any stenosis or narrowing of the vessels before ECMO introduction. Carotid Doppler may be indicated in patients with old age to exclude any cerebral ischemia or carotid insufficiency, which is very important to alarm this pathology for anesthesia. Ventilation perfusion scan has a limited indication in lung transplantation, only used in cases with single lung transplantation to select the least perfused lung and the most compromised lung. Also, if we plan for lung transplantation without ECMO or partial ECMO. Mammography is indicated for every female above 40 years old selected for lung transplantation to exclude any non-manifested or asymptomatic breast pathology on top breast cancer. Coronary multi-slice CT angiography may be an alternative, a good alternative for invasive coronary catheterization in patients with suspected any underlying coronary artery disease. DEXA scan may be indicated in patients with suspected osteoporosis, because osteoporosis is one of the relative contraindication for lung transplantation. It was a very long and difficult trip to Japan, وكان ليا الشرف ان انا اكون من التيم الاول اللي طلع اليابان مع رفقه خير رفقه يعني بمساعده الجامعه ورئيسهم الدكتور محمود المتيني. كانت رفقه كويسه، اتعلمنا منها كتير وفرقت معانا كتير، واي هوب ان احنا نعرف ننفذها على خير ان شاء الله باذن الله. شكرا.